What's interesting about this, if you take the longer view, is what is a hospital now in the 21st century? What exactly
Good
defines a
question.
hospital versus urgency care, or etc.
That's a really good question. I can tell you the traditional definition, but currently it evolves every day with telemedicine is the biggest change.
Yeah.
You know, now people can see their doctor online, face-to-face on computer, simple diagnoses made, even dispense medications of a medication box that's hooked to their computer with a lockbox on it that dispenses their medication to them. I mean, it's gone the whole gamut to the point where, I remember, the futuristic things where you talk to a robot, the robot makes a diagnosis, and I still think you cannot eliminate the personal touch, the palpation of the body by the physician, the physical diagnosis, laying on of the hands. I don't think that can ever be eliminated.
Yeah.
So outcomes, you intuitively thinking, you would think outcomes are the most important thing, but not traditionally. The American Hospital Association and the other regulatory body that watches us, a lot of times they're more concerned with process. They don't care about the outcome. As long as you cross your T's, dot your I's, the outcome is superfluous. You keep records of your infection rate or your timeouts are perfect. They care more about that than, oh, the patient died on the table. It's okay, you did an appropriate timeout, and your instrument count was correct. You may have a good idea how to make a healthcare system work, but what complicates it, you have to see how a healthcare system works within this GBR, this new payment scheme, global budget revenue, which the big buzzword now is population health, where hospitals get money. I think the state is in cahoots with insurance companies. They decide on how much money hospitals should get to pay for a service to take care of a life in Kent County, let's say. Let's just say we'll give you, $80,000 per head this year to take care of that life, and you have to work within that budget. So you have to work within that framework as opposed to, just try to lower your costs by eliminating unnecessary diagnostic tests, more efficient delivery of care in the hospital, no redundant tests, redundant services, and that kind of stuff. So we have to make the suggestions fit within GBR, is what I'm saying, as opposed to a traditional system where just reduce costs. GBR, you make money by keeping people out of the hospital. They go under the premise of, keep the patient, they're into wellness. But to be honest, they don't do anything to help the primary care physicians here in the community to keep people out of the hospital. They're just more concerned about readmissions for congestive heart failure, let's say. We have a lot of geriatric patients, and unfortunately, towards the end of life, people fail gradually, and they get readmitted for this, you fix that, they get readmitted for that. They don't care if it's a different disease process. If they're readmitted, you get dinged. You get dinged by the regulators. This was unnecessary. Patient should not have come back. I don't know the answer to that. I don't know how to respond to that, because people get old, they fail, and then they die. And the body's a unique physiological organism. It's not a machine. So these regulators, I think, are out of touch with the trenches. I was unhappy 8 or 9 years ago when we merged with Maryland. I gave them benefit of the doubt that they were going to enrich us. They made a whole bunch of promises, none of which they've lived up to. Among them were, they have lived up to pumping some capital into renovations, but if you look closely, all these renovations fit into a plan of theirs. It doesn't fit into a plan to maintain this inpatient facility. For instance, They pumped a lot of money into the emergency room. That would fit into any futuristic plan, regular hospital, urgy center, whatever. They promised to bring in and retain more specialists, more primary care doctors. The staff here is aging. I can't remember the last time they've recruited a new doctor for here. We have had some new doctors come through here, and they eventually leave not too long after getting here.
Why is that?
Well, I think that's it. It's family decisions. You know, say the wife is a physician, the husband can't find a job here, and vice versa. And so, and the school system's another big issue. It's gotten down to money. We had an attrition rate here. They talk about dropping volumes here. That's another complicated issue because a lot of things happen at the same time. We merged with Maryland. The recession hit us pretty much the exact same time. University of Maryland had plans for a hospital back then down in the vicinity of Talbot County. And when the recession hit, all those plans fell apart. And they rejuvenated this new plan lately. But you can see the writing on the wall. Gradually, they've made changes. They've consolidated resources from here. They put money into the ER, but not into other places in the hospital. So I'd listen to Kozel, CEO of Sure Regional Healthcare System. And it may not be his fault entirely, but he would tell us constantly that, you know, it's changing healthcare environment, which we know. He didn't go into details about the reimbursement scheme, but if you're sharp enough, you can read into how that would affect us here. They save money by lowering overhead. That's how they save money. We're always short nurses on the floor because it's a fine line between having just the right match ratio of nurse to patient, okay? But they err on the side of having too few nurses for the number of patients. They promised to be doctor friendly. They weren't. They promised to retain and refresh our medical staff. They didn't. They allowed ear, nose, and throat specialist retired and replace him. They drove the ophthalmologist away. Orthopedics, the total joint program has dwindled, and they've not replaced operative urology. These were big volume makers in the OR, and they haven't attempted to replace any of that, which tells you they're not interested in volumes. They want to get paid for that life, but they don't want the patient to come to the hospital. But what bothered me was consultants came into town and decided that, and these consultants never spoke to me, never spoke to any doctors. I doubt very much if they drove to Rock Hall, spoke to any citizens. I think they just audited the books and decided, here's what we recommend to the big board. The point being, they've disempowered us, taken away our voice. And so these consultants recommended that Chestertown look into establishing a ambulatory service hospital with or without a surgery center. And the question was, what's this ambulatory service hospital? It's a new term. No one knows the definition of it. Now we can use that perhaps in our favor to be the prototype. Maryland seems to be the prototype in a lot of things. We're the prototype in shock trauma, prototype in health care reimbursement. Maybe we can establish what this is. But we've been told on all different levels by different people that this does not include inpatient care. And I ask myself and ask other people, by definition, isn't a hospital an acute care? Doesn't a hospital imply certain services, not just ambulatory services? So in the meantime, hearing all this, I'm thinking, I've had enough. I'm tired of listening to this. I'm tired of them shoving it down my throat. Doctors have the power. The people have the power. And I was tired of Sure Regional treating me like just a commodity. I've been here 32 years, And someone who's been at any job for 32 years
Right.
should gain more respect. And they treated us like a commodity. I just got fed up, and everybody else got fed up, and I got together with some people and said, let's do something, even if it doesn't change the course of history. At least I won't feel guilty that I didn't try.
Yeah, of course. Yeah.
So
Yeah.
the point being, I want to maintain inpatient care at this facility. That means you're sick, you come in the emergency room, your illness is of enough severity where you need to be admitted to a hospital to get IV antibiotics, close observation, more diagnostics to figure out what's going on with you, things of that sort. Their new model, you'd have to ship everything from this Urgy Center
Yeah.
to, in their model, to this new Mecca in Easton.
Right. Right.
Now, another hint that makes us suspicious, they said none of this happened for 5 to 7 years, yet last week they just let go 8 people here. So how can you, yet they say, oh, there's no decision been made on inpatient care or not. But if you're letting all these people go,
Do they let them go?
I may be wrong that Shore Regional is not planning to eliminate inpatient care, but I'm about 99% sure they are. And I can't do it myself, so I'm trying to gather strength with numbers.
Okay.
I don't have a big axe to grind, to be honest. 90% of my surgeries are outpatient.
Yeah.
I could survive just with a surgery center.
Yeah.
So I'm not doing this just myself. Plus, I'm not a spring chicken. And so I don't have many years to grind out.
Yeah.
So I'm really doing it for the community. You know, after 32 years, you get attached to the place. It becomes part of you that you don't even realize until you sit down and someone tries to attack the integrity of this institution where you've been at. I told the guys in Easton, I'm not going to partake in a mechanism that's going to dismantle this institution I've been at for 32 years. I'm just not going to do it.
Is it past the point of no return, or is there?
No. I mean, here's what we have to do, and I put this in writing here, is we're willing to work within this GBR framework because that's the way Maryland does it. Though, just to get off track for a second, there's an entity called Critical Access Hospital, which is reimbursed at a different rate. This hospital in this community actually qualifies for that, but Maryland doesn't participate in this federal flex program, which would even allow a critical access hospital to exist. So another parallel thing I'm doing is initiating this hospital to qualify as a critical access hospital, but it's a lot of red tape. It has to go through CMS. Yeah. There's criteria. You have to be 35 miles from the nearest hospital. You have to be in a rural area, which is defined by CMS, even though by all
They say, I've been looking at
by all
this.
accounts they call us rural here.
Oh,
Even Shore Regional calls us a rural hospital. The length of stay has to be less than 4 days. All these things we can do. It has to go to the Maryland Survey Agency. That's where I start. That's where I have started. And they will take it to their bosses and take it to CMS to get approved. And CMS sends people out here to evaluate it.
Yeah.
And then it's got to go, I guess, to the legislature to be approved.
So
What it would take is pumping money into this place to improve the reputation. Right now, the community has a skewed opinion of this place. And it really hasn't changed. It's just they hear of all this turmoil going on here, and they've lost confidence. So they need to pump money into public relations here. Just get in touch with the community again. Have town meetings, but basically talk to the doctors, and we can try to get the community physicians to reestablish relationships with this hospital to keep them here, maybe get more specialists here, pump money into getting more sophisticated, diagnostic equipment, and just put on shows and attract, tell people, hey, you don't have to go to Annapolis, you don't have to go to Baltimore, you can stay here. Well, I'm trying to retain care and the welfare of this community. period.
Yeah. Yeah.
We're an elderly community, geriatric community, and these people can't travel, period.
Yeah.
It's just not feasible what they want to do. It's just not.
Yeah.
Their mission statement, they don't even oblige their mission statement to provide accessible, convenient care. So if you close the hospital, where's the access? Where's the convenience?
Yeah.
That's in their mission statement from 2015.
Yeah.
All right, that's fresh off the press. So it's just a lot of rhetoric and baloney, and I don't like baloney.
Yeah.
Never did like baloney.
Yeah. Well, you're from New York.
Yeah,
so-
that's right.